What are the main routes of toxicant absorption in animals? The primary routes of toxicant entry into the body are oral, gastrointestinal, inhalational, respiratory, and dermal, skin. For example, ingestion of rodenticides, oral, inhalation of pesticide sprays, respiratory, or absorption of chemicals from topical applications like flea dips, dermal, all lead to systemic exposure. Each route has different absorption efficiencies. For instance, carbon monoxide is highly absorbed via the lungs, while many pesticides like permethrin can slowly penetrate through the skin, especially if the fur is shaved or damaged. Why is dermal absorption unique compared to other routes? Dermal absorption is unique because the outermost skin layer, stratum corneum, is made of dead cells, corneocytes, which lack active transport mechanisms. Therefore, toxicants must penetrate through lipid-rich layers to enter circulation. For example, organophosphates like chlorpyrifos are more hazardous when applied to thin-skinned animals like cats or young calves. In such cases, even a seemingly low dose can be lethal due to compromised barriers or increased lipid solubility of the toxicant. What factors influence the distribution of toxicants in the body? Distribution is influenced by the toxicant's lipophilicity, molecular weight, degree of ionization, plasma protein binding, and tissue affinity. For instance, lipophilic compounds like DDT accumulate in fat tissues, while cadmium accumulates in the kidneys due to metallothionein binding. Drugs like warfarin bind heavily to albumin, reducing free circulating levels. Additionally, barriers like the blood-brain or blood placenta prevent many hydrophilic toxicants from entering the brain or fetus, though lipophilic compounds like ethanol can easily cross. What is meant by plasma protein binding and how does it affect toxicity? Many toxicants bind reversibly to plasma proteins like albumin. Only the unbound, free, portion is pharmacologically or toxically active. For example, if a toxin is 95% protein-bound, only 5% is active at any time. However, in cases of hypoalbuminemia, for example, liver disease, the free fraction increases, leading to exaggerated toxicity. An example is phenylbutazone, which becomes more toxic when protein binding is reduced, increasing its risk of causing gastric ulcers and kidney damage. What happens when a toxicant crosses the blood-brain barrier? The blood-brain barrier, BBB, is a selective gateway that restricts most toxicants from entering the brain. However, small, non-polar, and lipophilic substances like ethanol, cyanide, or organophosphates can bypass the BBB and cause CNS effects such as seizures or coma. For instance, ivermectin crosses the BBB in collie dogs with the MDR1 gene mutation, leading to neurotoxicity. Understanding BBB penetration is critical when evaluating neurotoxins or selecting drugs for CNS infections. How does metabolism, biotransformation, affect the toxicity of a compound? Metabolism usually detoxifies a compound, converting it into water-soluble forms for excretion. However, sometimes it can activate a compound into a more toxic metabolite, a phenomenon called bioactivation. A classic example is acetaminophen, which is metabolized into a toxic intermediate, NAPQI, in the liver, especially in cats who lack sufficient glucuronidation. Another example is aflatoxin B1, which is metabolized into a reactive epoxide in the liver that binds to DNA and causes liver cancer. Why is excretion important in toxicology? Excretion is how the body removes toxicants, mainly through urine, feces, or exhaled air. Rapid excretion reduces toxicity risk. For example, water-soluble substances like ammonia or ethylene glycol are quickly excreted by kidneys. In contrast, fat-soluble toxins like dioxins are slowly excreted and tend to accumulate. The lungs also eliminate volatile compounds like anesthetic gases or carbon monoxide. Liver damage or kidney failure can impair excretion, leading to toxin buildup and worsening toxicity. What is a traditional, compartmental, toxicokinetic model? A traditional or compartmental model simplifies the body into one or more compartments based on how a toxicant distributes. For example, a one-compartment model assumes instant and uniform distribution used for drugs like caffeine. A two-compartment model includes a central, blood, and peripheral, tissue, compartment, such as with digoxin. These models help predict blood concentrations over time using exponential equations, though they do not represent real anatomy. What is a physiologically based toxicokinetic, PBTK, model? PBTK models are more sophisticated. They use real anatomical and physiological data to simulate how a toxicant behaves in each organ, for example, liver, kidney, fat. For instance, when modeling drug residues in swine meat, a PBTK model can predict how much drug is present in muscle or liver at a given time. These models are useful for interspecies extrapolation, dose-response analysis, and simulating real-life scenarios like repeated exposure or metabolic differences across age groups. Why are PBTK models preferred in modern toxicology research? PBTK models allow accurate predictions of tissue concentrations, help in setting withdrawal times in food animals, and simulate various conditions, age, breed, disease. For example, a PBTK model helped determine how long sulfamethazine residues stay in pig tissues post-treatment, ensuring food safety. These models can also incorporate Monte Carlo simulations to understand variability across populations. Though data-intensive, PBTK models are increasingly used in regulatory risk assessments due to their precision and realism.